Thank you, Dr. Muhammad. I would like to thank the organizing committee for inviting me to give this talk. Alhamdulillah, we have Dr. Mustafa Shazli, another surgeon in the room, because it's not very safe to be around so many endoscopists by myself. Anyway, as we said, we all work for the patient benefits, so let's hope cooperation is the energy in the room. So who's appropriate for the OR? I wish it was a very simple answer that a patient who is not responding to PPIs, but life is not that simple, and GERD is a very complex issue that needs to be taken very cautiously. I will try to touch on the pathophysiology, try to define what is an successful anti-reflux surgery. I cannot overemphasize the importance of proper patient selection for a good outcome. The key components of preoperative workup, we already heard about that, and try to make a distinction between what is very clear for surgery and what is really needs to be taken into very careful steps. There are 4 mechanisms that guard against the injury of the esophagus from the acid. The clearance mechanism by proper peristalsis, the mucosal integrity, lower esophageal sphincter competence, and gastric emptying. Unfortunately, number 1 and 4 usually are not looked at very carefully. And this is very, very important if we are going to consider surgery to look at these 2 in particular. Medical therapy, of course, has become the cornerstone of dealing with GERD, as we heard. PPIs, they result in a very, very successful management for most of the patients, but you will still have a subset of patients with a persistent symptom that will be nagging you to do something else other than the medications. The surgical therapy, it restores the lower esophageal sphincter integrity. And the laparoscopic fundoplication, whatever the type, has become the gold standard in surgery. But we need to slow down to see the conceptual differences between the medical therapy and the surgical therapy. Because surgery, it does not affect the acidity, it affects the reflux. So it's a mechanical form of management of the disease. The medical therapy, it does not affect the reflux, it affects the acidity of the reflux. So it's more of a physiological nature. So they are conceptually different. So what's successful outcome of anti-reflux surgery anyway? You need the patient to have symptom improvement or resolution, to avoid operative complication, and to have minimal post-op symptoms. But the first key to a successful outcome is a proper diagnosis of the patient and symptoms. This is very, very important. Patient selection is paramount, and what we have heard about, listen to the patient, talk to the patient, have a proper history is very, very important. Accurate clinical history is at the core of the whole thing. And we have in our armamentarium the 4 major investigative tools: the upper endoscopy, the pH monitoring, the manometry, and the upper GI series. But if you listen very carefully to your patient, you might need something else, like gastric emptying time by scintigraphy. This is an overlooked investigation that you need to do, especially if the patient also is complaining from vomiting together with GERD. This is very, very important. And we always have to remember that GERD is at the center, and it intersects with 2 other pathologies, which are achalasia and delayed gastric emptying. So you need to, if you are going to embark on surgery, you need to clarify where you stand on these 2 issues. Here we have the candidates for surgery, and we have in greens what is a clear cut state for surgery. We have a little bit of green and yellow, and then we have the yellows. And the yellows, we need to be very careful while approaching them. If you have an objective evidence of GERD, the patient has severe erosive esophagitis or stricture, this is a clear-cut case for surgery. The patient has an objective evidence of GERD, and usually they do very well. The persistent regurgitation. As we said, conceptually, PPIs or the whole medical therapy, it will not prevent the reflux. It will change the acidity of the reflux, but it will not prevent the reflux. So if you have a patient who is refluxing and fluid is coming out of his nose, he will not be helped with some pills. It can be lifestyle limiting, and restoring the integrity, the mechanical barriers against reflux is very important, and this is only achievable by surgery. If you have an associated anatomical abnormality like hiatal hernias, this is also a very important thing to consider surgery in these patients, because again, you need to restore the mechanics for the prevention of the reflux. Young patients are, these are the yellow and green. We know that because GERD has developed at an early stage, the long-term progression of the disease is to be waited for. They get good relief with anti-reflux surgery, but the younger the patient, the more potential years of failure of your surgery. So you need to be very careful not to rush the patient to surgery, or to really discuss with the patient the risk assessment for the probability of recurring and resurgery down the line, maybe in 10, 15 years later on. So these patients need to be taken very carefully. Another category, the extraesophageal patients with GERD, it's very difficult to link GERD directly to the extraesophageal symptoms. It's very, very difficult. It might be suggestive, but it is very difficult to prove it. GERD can be causative or just a contributing factor. If you can prove somehow that the patient's symptoms related to GERD and his pulmonary problem, he will do well with the surgery. But these patients need to be taken very, very carefully and not to rush into surgery right away. And the very, very big issue of Barrett's esophagus. This is a very big topic, and we need to look at it very carefully. Does Barrett's esophagus regress after surgery or after proton pump inhibitors, for that matter? This is a big question. But is it the right question? I don't know. This is a graph that shows the increase in the incidence of gastroesophageal carcinoma in the United States from the late 70s of last century up to the first decade of this century. And you see the rise, it has become sevenfold. The incidence has become sevenfold of the gastroesophageal cancer. And we see here in 1990 was the introduction of the PPIs. So introduction of the PPIs did not alter the increase in the incidence of gastroesophageal carcinoma. This is a question that needs to be addressed. I think the better question than does Barrett's regress after medical or surgical therapy is, can we prevent Barrett from progressing into gastroesophageal carcinoma? Barrett in itself is not the problem. The problem is the progression of Barrett into a gastroesophageal carcinoma. So this is the real issue. So PPIs are very, very effective in controlling the acidity. So why gastroesophageal carcinoma is still occurring at a high rate even with the PPI usage? This suggests that the refluxate contains some other carcinogen which might be the bile acid, that refluxes anyway, and PPI only works on acidity, and it might cause the injury of the mucosa. But so in theory, surgery, because it prevents the reflux altogether, not just the acidity, should have a better control on the development of or the progression of Barrett than the PPIs. But this in reality, it has never been proven in any study. And this is a meta-analysis. It was published in 2016, comparing surgery and medical therapy, and it has not yielded any result in either arms that it is better than the other in controlling the progression of Barrett. And here we have to discuss the difference between non-dysplastic Barrett and dysplastic Barrett. This is very important because the risk of development of cancer in a non-dysplastic Barrett is so small, it's less than 0.25% per year. So if you look at it, how many patients do I need to treat to prevent one case of esophageal carcinoma? You will have to operate on 800 patients. 800 patients to prevent one gastroesophageal carcinoma in a non-dysplastic Barrett. So this has to be taken into very, very serious account. We should never present to the patient anti-reflux surgery as a protection from malignancy per se. If the patient is not controlled by medical treatment as a GERD case, he should be operated upon, but you should never offer surgery as an anti-neoplastic procedure. And this is the ACG also recommendation. Anti-reflux surgery should not be pursued in patients with Barrett's esophagus as an anti-neoplastic measure, only if the patient symptoms is uncontrolled. Patients with obesity are also patients to consider very carefully. If you have a patient with a high BMI, the higher the BMI, the higher the GERD. If you have a patient with a high BMI, he should have a bariatric surgery or lose weight. He should not have an anti-reflux procedure. And if you decide, if the patient is morbidly obese and he will go for surgery, he should have a Roux-en-Y gastric bypass and never a sleeve. Sleeve is a refluxogenic procedure by nature. If you do it with a patient who's complaining of reflux, he will develop his life into hell. So if you are going to have a surgery for the obesity as well as controlling of the GERD symptoms, the operation of choice is Roux-en-Y gastric bypass. It will decrease the abdominal pressure and it will decrease the acidity also from the small gastric pouch. There are very small technical points from a surgeon's perspective that needs to be taken into account regarding GERDs. What we said about manometry is very important. Any surgical patient who is going to surgery without a prior manometry, I think is a big mistake. You do not know the motility. If you do a 360 wrap, a Nissen fundoplication, the patient will develop very severe dysphagia. You need to clarify the integrity of the peristaltic movement of the esophagus prior to any fundoplication procedures to be done, because you might resort to 270 wraps like the toupee or the door. This is one thing. And the other thing is the short esophagus. This is, it must be taken into consideration. We need a 3 centimeter intra-abdominal esophagus for prevention of the reflux and for prevention of the recurrence of the problem again. So if you have a short esophagus during surgery, you need to do a technical procedure to lengthen the esophagus, and the procedure that we do is called the Colles-Nissen augmentation of the esophageal length, and then you do the wrap properly on the esophagus. So these are the really the main categories in conclusion, we only treat typical symptoms, the heartburn and regurgitation, all the complications, strictures and refractory valves, or the hiatal hernia. We should take into very cautiously patients who are young, with respiratory symptoms, with uncomplicated Barrett's, and all the obese patients. Thank you very much.